Hello, this video is for the recent graduate programme part of the Langford Academy. It's free to our members, so please sign up on the website. My name is Christina. I'm one of the internal medicine clinicians at the Langford Referral Hospital, and in this first video I will be talking about the medical approach to acute vomiting in the dog. So our first priority is to differentiate whether this is true vomiting or actually regurgitation, remembering that a patient could present with both. And the most important thing here is really a careful history. We need to see active abdominal effort to know that this is vomiting. Some patients can show altered behaviour when they feel nauseous. They may salivate or drool, swallow or lip lick, but that can also be seen with silent regurgitation. There are also descriptions in some of the textbooks over the nature of the vomit, association with feeding, pH, content of bile, but these are not specific. The most important thing is active abdominal effort. It's the contraction of the abdominal muscles and the diaphragm that forcibly expel the contents up and out of the mouth. Our second priority is to determine whether we think the patient could be managed as an outpatient with supportive medication given at the surgery and then at home, or whether we need to admit the patient. And that's going to depend on our physical examination and also the history from the owner. Is the patient still eating and drinking? Can it maintain its hydration status? Do we think there's abdominal pain on palpation? Are the cardiovascular parameters increased? Are we concerned that the patient is already dehydrated or hypovolemic? Depending on our findings, we may perform some additional diagnostic tests. These may be quite simple, things like PCV, total solids and electrolytes. If our patient is slightly dehydrated and there's hemoconcentration, then the PCV and total solid may be slightly increased. With acute vomiting, unless there's been marked hematemesis, we wouldn't really expect to see a major drop in either of those parameters. And similarly with our electrolyte concentrations, if the patient's dehydrated, they may be slightly increased, or if we've got significant sodium and potassium loss in the gastric fluid or in the vomit, then those values may be slightly reduced. Again, depending on the clinical presentation and how worried we are about our patient, we may elect to do further diagnostic tests. That might also depend on the history and whether there is a known dietary indiscretion or potential cause for the vomiting. If not, we may look for non-gastro-intestinal causes, so for example liver disease, renal disease, and then perhaps depending on our sodium-potassium ratio, we may want to exclude hypoadrenocorticism. And then our next important rule out is, could we have a foreign body or intestinal obstruction, and do we need diagnostic imaging? So let's look at an actual case. In this instance, we've got a young, crossbred, male neutered with a 2-day history of vomiting and anorexia. We do have slightly tense abdomen on palpation. We've got tachy mucous membranes, slightly prolonged capillary refill time, and some tachycardia with hyperdynamic pulses. This is all leading us to feel that the patient is slightly clinically dehydrated, may even be hypovolemic, the abdominal pain is slightly concerning, and the patient does not appear to be able to keep fluid or food down. We perform blood gas analysis in this patient, and we've got 3 quite important findings here. So the first one, we're lucky enough to be able to measure acid base and the pH, and we've got slightly unusually an alkalemia. If we look at the bicarb value, we see that this is a metabolic alkalosis, and that's quite a specific finding, and it makes us concerned for gastric vomiting and potentially a gastric outflow obstruction or proximal duodenal obstruction. When we look at the electrolytes, we can see that sodium and potassium are reduced. That could be because we've got losses in the vomit, but importantly we've got quite a significant hypochloremia. Chloride ions are a major component of gastric secretions and gastric acid, So we worry that this is where we are losing the chloride ions and they're being either sequestered in the stomach or being brought up in the vomit. So a hyperchloremic metabolic alkalosis is really quite a pathognomic finding when we have pyloric or proximal duodenal outflow obstruction. The slightly increased lactate fits with our clinical examination and the fact that this dog is slightly hypovolemic with poor tissue perfusion. So we may well stabilise this patient as part of the medical approach, and we would give a fluid bolus initially. We often talk about using any isotonic crystalloid, but in this instance I would reach for sodium chloride because of the alkalemia. And probably give a 20 ml per kilo bolus, but we could do it in 2 by 10 ml increments if you prefer. And at that point we would reassess the cardiovascular parameters. Has the heart rate improved? Is the pulse quality better? And is the dog looking better? And if needs be, we would then give a further bolus if we aren't happy with the response in our patient. We would be then looking to perform diagnostic imaging to confirm our diagnosis and our clinical suspicion, and we would also be then talking to the owner about potential for surgery. If we are going to have to consider surgery, and we might be breaching both the gastric wall or the intestinal wall, then we would consider prophylactic antibiotics and administer them intravenously before surgery starts. And potentiated amoxicillin would be our drug of choice. So in the next video we will cover diagnostic imaging to try and confirm whether we have got a gastro-intestinal obstruction, and then in the final video we will cover potentially surgical technique and some of the principles for this. Thank you.